Well, good evening, everybody. Welcome to the third in our series of forums on the healthcare crisis. I'm Jim Perlstein, and I co-chair the PSC's Social Safety Net Working Group. The working group and the union's delegate assembly are the sponsors of the Task Force on Healthcare Reform, which has organized this series. For me, as a municipal retiree, the current crisis has been inescapable. The city seems hell-bent on serving money at the expense of my healthcare. But much as my fellow retirees in the public sector are riled up, efforts to arouse those younger and in service, to say nothing of those in the private sector, hasn't been easy. To us, it's obvious. We're the canary in the coal mine, convincing younger, healthier colleagues with lots of other concerns that the handwriting is on the wall for everyone, that our healthcare system is unsustainable, is a taller order than we thought. So that's why we're here, to catch up in order to move ahead. Edification as a path to engagement. Your task is to join us and to spread the word. In our first session, we reviewed the city's attack on retiree health coverage through the privatization initiative that triggered the current fight. We followed that with a review of the history of labor's engagement with the issue of healthcare, particularly in New York, and the alternatives to privatization that the city ignored. If you missed one or both, they're available on video. We'll put links in the chat. This evening, we want to look at the well-established drive to privatize health coverage, a major part of the relentless campaign to privatize all public goods. But most of all, we want to open consideration of single-payer insurance here in New York in the form of the New York Health Act as the appropriate response. Our presenter is Len Rodberg, Professor Emeritus at Queens College and former chair of its Department of Urban Studies. Len is a longtime advocate for single payer and serves as a primary consultant to Assemblyman Richard Gottfried, author of the New York Health Act. Len played a key role in drafting the act. Some housekeeping as we begin. You'll all be muted during the presentation. We're asking everyone to please respond to our survey relating to the series and our developing action agenda. Just click on the link that will appear in the chat. I hope more than once during this session. To question or comment, please raise the virtual hand that you can access under reactions that should appear on the lower right side of your screen. Don't wave your actual hand. You can also post a question in the chat. We'll establish a stack or a queue, and you'll be recognized in order. Please be brief. If your point's been made, you don't need to repeat it. The host will unmute you as you're recognized. Thanks. Len, take it over.
Okay, I'm glad to be here and glad to see all of you. Some of you I know from previous lives. I'm going to, as is customary with, with me and with Physicians for National Health Program, which is an advocacy group I work with. I'm using a slide presentation to sharpen the points I'm going to make. And as usual, I think I'm going to try to be as concise as possible so there's time for reactions and comments and questions. So, and you can reach me directly if you'd like through my Gmail account. So I should say that I've given a number of talks on Medicare Advantage and the privatization of Medicare. This is not about that. This is about the overall structure of the provision of healthcare, particularly the financing of healthcare in the United States for all of us, not just for we city retirees. So here's a bit of a background. Americans, almost all, when asked, believe that basically access to healthcare should be a right, at least for American citizens. Whether they agree that non-citizens or undocumented immigrants should have access is a debatable political question, but you can see that if that almost all of us agree on this. But we don't have that. We have still about 10% of Americans have no insurance, as measured by the Census Bureau, including 1 million New Yorkers. And we have a very generous Medicaid program that covers it covers almost a third of the population of New York City. And uninsurance doesn't count all the problems that people face, because we face substantial and growing, as I'll show you, cost sharing, skin in the game, as it's often referred, deductibles and copays, which affect many more people. So even if you have insurance, you often can't afford to use it because you can't afford the out-of-pocket costs. And they continue to rise. Here's 20 years of data showing the rise in cost over those 20 years for a family from less than $6,000 to over $21,000 a year. You can see why there's so many uninsured, why so many businesses can't afford to provide insurance. Small businesses especially can't afford to provide insurance for their employees because of the extraordinary cost of healthcare in this country. And that's not just inflation. What this shows you, the orange and yellow lines are the cost of healthcare, of insurance premiums, and the worker employee contribution to that healthcare. And the two bottom lines are wages and general inflation. The economy gets more efficient, more productive. So in the kind of society we had immediately after World War II, and say the first 30 years after World War II, workers would share in the growing productivity and wages would rise relative to general inflation. People would become, in effect, richer. That hasn't happened. This is just the last 10 years, but if you go back 30 years, you'll see the same thing. The gains in productivity are eaten up in two ways. I'm not going to give the larger talk about inequality, but we know that a lot of the share of growing productivity has gone to the very wealthy, but a lot of it goes into the rising cost of healthcare, which rises much faster than the wages of most of us. And our out-of-pocket costs go up as well. This is deductibles for single insurance policy. This is data, by the way. KFF is the Kaiser Family Foundation, and this is a survey of employers. This is based on a survey of employers because about half of all people in this country get their health care through employment. You can see that just in 10 years, the average deductible has gone from $600 to $1,600. This is for a single person. For a family, it's more like $3,000 to $4,000. Deductible means how much you have to spend out of pocket before the insurance starts to cover anything. This is what I mean by underinsurance, that people can't afford to spend the amount that would get them up to the level where their insurance would kick in. And of course, having no insurance is a burden, continues to be a burden. This is interesting. It shows both the increasing number. The drop is the passage of Obamacare, of the Affordable Care Act in 2010. And that made a big dent or a substantial dent. You can see $5 million or so, 5 million people or so in the number uninsured. But then with COVID and the big loss of employment, since people depend on their employment to get health care in this society at this moment, unemployment went up again. To me, this is the most important figure. And if you understand it and understand what's behind it, you can see the nature of the problem. We are exceptional and exceptional in a terrible way. Everybody else, every other major country, and what you're looking at there is the OECD, the Organization for Economic Cooperation and Development. It's the capitalist countries, major ones. Doesn't include China, but includes Japan, from Japan to Canada and most of the European countries. And you can see that as a share of their gross domestic product, they spend a little less than 10%, and it's relatively stable. The black line, of course, is the United States. We spend more and the costs keep going up. And the reason, I will explain the reason. What they know that we don't is that government has to oversee and regulate and sometimes fund healthcare. I mean, for many of these countries, I mean, take Germany and France are the prime examples. Government doesn't fund the healthcare, but it absolutely regulates it so that prices are contained and everybody has access to healthcare. As any of you who have traveled to those countries know, that you can, if you need a doctor or need some kind of service, you can get it even as a visitor. Now, here's a graph that has some similarity to the graph I just showed you. The bottom blue and green lines are our two major public insurance programs, Medicare and Medicaid. The orange line going up there, that's private insurance. This is the spending per person in each of these programs over the last 10 years. And there's an interesting thing, and you know, if you look at this graph and compare the previous graph, you can't miss the story. Public programs can control costs. Private insurance cannot. And but in this country, private insurance, the public insurance has to rise somewhat because it's got to be able to pay enough that physicians and hospitals will take the public coverage and not abandon it in favor of the more lucrative private insurance. So why is this? Well, that's a fundamental question. And an excuse that's often given, in fact, it's the excuse given by the federal government today, is that we use too much healthcare, that the fee-for-service system is increasing, you know, leads to an excessive use of health services, and we need to cut back. But here's a paper, this is 20 years ago, it's a classic paper. It was redone just 2 or 3 years ago. And what it found is in the headline, it's the prices, stupid, not our use of healthcare. It looked at the use of healthcare and found that, in fact, we use less services than the people in these other countries, but we spend more because the prices are higher. And here's 2 examples of number of physician visits per capita and hospital inpatient days per capita. In both cases, we use less services. They're more expensive, we use less of them. So why are they so high? This is the most important slide I'm showing you. At least it tells a big story, which you won't hear anyplace else. I was thinking it's sort of like people talk about how the parable of the frog and the water that gets heated up, or that do fish know they swim in water? We swim in a private market, and it somehow seems natural to Americans and to American economists that healthcare will be treated like a market, but no other country treats healthcare like a market. We allow prices to be set by the supplier of services, the doctors, the hospitals, the image services, and so on, the drug companies. And we allow the private insurers to set their premiums, to negotiate whatever they can or want with the providers, and then to set their premiums however they want. It's not regulated. I mean, the insurance companies are regulated by states to keep them solvent so they can meet their obligations. But what they charge by and large is not regulated, and certainly not regulated by the federal government. Every other country uses administered prices, that is, prices that are controlled by government. And Medicare already uses them. that's why those two graphs, the international graph and the domestic graph, have that similarity, because the Medicare and Medicaid use the same procedure of administering, setting the prices, and requiring that the providers follow those prices rather than setting their own. Because this is the same procedure that the major countries in the rest of the world use. And the story that I'm leading to, and the point that I'm leading to, is that a single payer, what used to be called national insurance program, would use administered prices to control costs and assure universal access without having to pay at the time of service. As I said, about a third of all countries don't, well, they don't use copays. Canadians have no copays when they go to see a doctor or a hospital. Americans say, well, if you don't have copays and aren't required to shell out money, people will go wild in their use of health services. Well, it's not true. And I've got a paper that shows that explicitly. This is the major story I'm telling here, which is that it's our reliance on private markets, not the fault of the insurance companies in particular. They're part of an assumption that healthcare is a market, and it's not a market. People can't negotiate the prices when they go to see a doctor. First of all, the prices aren't public. Secondly, you don't know what the healthcare will cost, because you don't know what the process of care will lead to, how long it will last, what kind of treatments will be needed. It simply doesn't meet the requirements that, you know, economics 101 requires to have a market where the buyer and the seller meet on a level playing field. It's not a level playing field. When you go to a doctor, you got to put your hands yourself in the hands of the doctor who's been trained to know what best to do. So if the market doesn't work, and the international graph shows the result of our reliance on a market, of a rising cost, high and rising cost, what's the public route? Well, the public route is single payer system. Nationally, there are two pieces of legislation in the Senate and the House. They're slightly different, but the fundamentals are the same. They extend the principle of Medicare, which is general tax provided healthcare, access to healthcare for everybody, comprehensive benefits, including long-term care, which isn't provided for in any health insurance system today, any private health insurance today. A free choice of provider, meaning no narrow networks. Everybody, I mean, more than 90% of all physicians are in Medicare today. You probably can't force a doctor to be in this program, in this national program, but if they're out, they miss a lot of patients. And you, of course, want as many in as possible. No cost sharing. There's no requirement that you put up money at the time you're going to seek care. It saves the system money because you get there earlier and your treatment that you need is less intensive. A public agency, government agency, pays the bills, and it's funded by progressive taxes. The kind of taxes are not specified too clearly in any of these piece of bills. That'll be part of the negotiation when we can get to that. Here in New York State, we have what I believe is clearly the most progressive single payer piece of legislation in any state in the nation, and with the most support. It has co-sponsorship by a majority of both houses of our state legislature. It would, just like the national program, set up a single state fund that covers every resident, not every citizen, every resident of the state. You have to define resident, of course, in some regulation, like, being here 3 months. You don't want people flying in, getting their brain surgery and flying out again, but it's every resident and every full-time worker. That's to keep it simple for employers, so they don't have two classes of employees, those that are covered by the state and those they have to find private insurance for. Comprehensive benefits, including long-term care, no deductibles and no copays. It's more trouble than it's worth in terms of that doesn't save money, and it's an administrative headache, and it keeps people from getting the care they need when they need it. In terms of Medicare, it covers the Medicare Part B and Part D premiums that all of us on Medicare pay or have taken out of our Social Security checks. It's funded by the existing public funds, by Medicare's money that Medicare now spends in New York, the federal government's contribution to Medicaid and to the Obamacare, and by progressive tax on payroll and non-payroll or investment income. And the important thing is that it costs less than we're now spending. The care is more comprehensive, but it costs less because of the savings. There's savings in three ways. First of all, here are the benefits. It's interesting legislation. It's different than most healthcare legislation you see, like including the federal plans. It doesn't say what's covered. It says, what plans do we now have that cover the kinds of things that will be covered? So it says that anything now covered by the Children's Health Insurance Program, Medicaid, Medicare, state's Medicaid program, Medicare, or health benefits for state and retired state employees. So anything you can find in any of those plans, like acupuncture, you can find in Medicaid, and of course, long-term care in Medicaid. So in fact, when the original version of the bill didn't include long-term care, because it had a clause that said everything in Medicaid except long-term care was the original version about 5 years ago. And then about 2 years ago, that clause was removed. So it now covers long-term care. And it covers dental, vision, and hearing care, which Medicare does not cover, but Medicaid does. And health benefits that the state provides employees does also. So where are the savings? Well, first of all, the overhead of a government-run program is a lot less than the overhead of private insurance. Private insurers require that you get approval from them for anything that's likely to cost a substantial amount of money. We've set up this system of perverse incentives where insurance companies make money by not delivering care, by avoiding very expensive things or postponing it or getting you to go to a cheaper provider. Federal government doesn't do that. The Medicare program doesn't do that. If a doctor wants a treatment gets done, paid for by Medicare. Then, of course, there's marketing. There's their advertisements to get you to buy their insurance rather than somebody else's. There are the million-dollar salaries, multi-million-dollar salaries they pay their executives. And, of course, most of them are for-profit, including Empire Blue Cross here in New York City and state. But whereas Medicare's overhead's about 2%, it's the cost of processing the claims, which they usually actually have done by private entities rather than set up their own computers. There are savings on the part of the people who provide care because they don't have to deal with insurance companies, with the multiple confusing plans, with trying to get approval, because when the prior approval arrangement works from the doctor to the insurance company, not the individual. So the doctors save on that. So here's a comparison of the annual cost of administering their office for a Canadian doctor and an American doctor, and it's extraordinary. The savings you get. Hospitals have the similar kinds of savings because their billing systems are much simplified. And finally, there's drug costs. No other country but ours allows drug companies to set their own prices. And they're the same drug companies. These are multinational corporations, often based in Switzerland or Germany or other places, France. In those countries, the price of drugs is regulated. In the United States, it's not regulated. And the result is that on average, we spend twice as much per person on drugs as the average of the other OECD countries for which the data is available. So those are the three major ways in which you save money on a single payer system by reduced overhead costs for insurance administration, reduced costs on the basis in the offices of the providers of care, and reduced costs of drugs. And both the RAND Corporation and then some study I following up the RAND study, found that this plan, in spite of the fact that it covers everybody, it has no cost sharing, and it has long-term care, will still save money overall, billions of dollars a year. And it's in the ways I just said. There are three sources of savings: from reduced administrative costs for insurance, reduced provider costs, reduced prices for drugs. There are extra costs. When you cover everybody and eliminate cost sharing, people get more care. There are more people getting care and they get more care. We also raise in our estimates of the cost, we raise the fees that providers get because Medicaid in particular doesn't pay doctors enough. That's why one of the reasons why a lot of doctors don't take Medicaid. And then we added long-term care, and this is Rand's estimate, and we did a separate estimate of what it would cost to extend long-term care to people who are not poor, who are not spend themselves into poverty, which is what it takes to get on Medicaid. And the net result is net savings, and this is the result. Been updated and find similar about continued savings today. So again, so the costs are less, and the costs are less going into the future because you can contain costs. This is the same slide I showed you earlier. Public programs can control costs, control the rate of inflation, and private insurance cannot, but public programs can. So the real way you control costs is to adopt a single payer national program. And then you set prices the way other countries do and the way Medicare does, by negotiation between the government, which is setting the price, and the physician and hospital organizations that represent those providers, those and other providers of care. Didn't list them, but of course you have dentists and so on. What's the overall perspective then? But well, it's good for particularly the New York Health Act. It's good for New Yorkers. It guarantees access regardless of anything. So that if you live here, you're in the program. Losing your job doesn't mean you lose your health care. You don't have to spend down to poverty to get long-term care. You don't face any financial barrier. If you feel you need care, you go seek it. You may be told you don't really need it. Take 2 aspirins and call me in the morning, kind of thing. But you can do it without facing a $50 copay, which is what you're likely to face if you go to an emergency room. There's greater equality of access, and of course we know there's apartheid in New York City and American healthcare in general. The people of color and the poor face one kind of healthcare, and people of means get a much better quality. This will tend towards equality. It won't lead to it immediately, but when Medicare came in, it broke the barrier of segregation in the South and Southern hospitals, and the same kind of thing will happen here in a more, I think, probably in a more gradual way. And then, of course, there's public accountability, that because you have government funding it, and the government is responsible then to see that people get access. It's also good for unions. First of all, the major problem that unions face today in wage negotiations is paying for their health benefits. First they have to do is make sure they keep their health benefits, and the health benefits have now cost more than they did last time they negotiated, so they have to give up wage increases, and this will remove that. You won't have to negotiate over wages anymore, over healthcare anymore. You can negotiate over wages and over other kinds of social benefits. And you can focus then on them, and everybody will be more secure because you don't have to take a job because it has insurance. You don't have to stay in a job that you hate because it has insurance. And it will be another victory for the labor movement. We haven't had many lately, so it'd be good to get one here. So there is a campaign for New York Health. Many organizations, several unions, particularly the nurses union and the hospital workers union, are strong advocates. Our union supports it as a work in progress. It is not sort of a full-throated support and advocacy. You won't find it on this list, but a lot of grassroots organizations are here, and there's an active movement, largely at the grassroots. The unions are Many unions are on paper supportive of single payer, but in practice, when it comes down to the possibility of actually passing it, they discover that they've got too much of their livelihood, they're too much invested there. In fact, the way I put it, and I'll be willing to argue this with people, is they're part of the health insurance industry today. They negotiate it, and then for their members, they help run it, help provide it. And so it's a big stretch for many unions to transfer the responsibility for health benefits to the government. But the experience of the rest of the world has shown that that's the way you can control costs. You can't do it on an individual or a market basis. So our union has set up a healthcare reform task force, and a number of us are working on it to help educate the CUNY community, both the faculty, the staff, the students, about the New York Health Act and why it's good for CUNY and good for the people of CUNY. And I urge you, and we on the Social Safety Net Committee and the task force urge you to join us in the effort to spread the word. So thank you very much.
So thank you, Len, and we'll open it to questions and comments.
But you have to raise your Zoom hand.
So there is a question in the chat. If it's a victory for the labor movement, please explain the resistance of some unions to it.
Well, are we going to? We had talked about accumulating 3 questions.
Yes.
But,
well, okay. The other question is, isn't the question net savings for whom? Right now, the state of New York doesn't pay all those expenses, so it would have to raise taxes when all the politicians tend to run on cutting taxes.
Well, we're cutting let me deal with that first. What this does is to eliminate insurance premiums. So, and insurance premiums are sort of the ultimate regressive tax. The saying is the secretary pays the same premium as the boss if they have insurance. All the legislation I'm discussing provides that the taxes will be progressive. Many of us believe that, but the legislation, the New York Health Act, for instance, doesn't specify what the taxes are. It says they'll be based on payroll and there'll be taxes on non-payroll income, but doesn't say what those taxes are. And that's one of the things the unions point to when they express their resistance is, how do we know it'll financially benefit our members? We don't know what it'll cost. So many of us think that the New York Health Act should have the taxes built in. They can be changed later, but at least the legislation would say what the taxes are. And if the program is run properly, the tax rate can be set, doesn't have to be changed. Medicare taxes were set in 1983 last, and the program is solvent, and the hospital insurance taxes that we pay for Medicare. There will have to be taxes, but there won't be premiums, and there won't be out-of-pocket costs. And many city workers don't pay premiums, but they pay deductibles and co-pays. And this plan I'm talking about, none of these plans has co-pays and deductibles. They're part of the market system that says you got to have people have skin in the game. Well, a lot of people don't have much skin, and they don't get in the game. And the object here is to have everybody have access to care. That's the basic principle, universal access. And the only way to have that is to not face financial barriers when you're seeking care. Now, in terms of unions, the thing is, unions are used to as one way to look at it is, especially for public unions these days, with the Janus decision, the union leaders worry that if they don't provide benefits, people won't join them. Well, people will join them if they're doing other things for them, like negotiating decent wages and wage increases and disability benefits and legal benefits and childcare and a variety of other things. Other countries have much stronger union movements than we do, and the government provides the healthcare, and they provide it because the union movement helped build those universal systems, mostly in the period after World War II. What we built is this private insurance, employment-based insurance system, of which the unions are a part of now because they negotiate it. Many of them get funds that maintain welfare fund offices and buildings. They have a financial stake. Here in New York City, the head of one of the city employee unions is on the board of Emblem Health Insurance Company, GHI. There's a real interlocking of the unions with insurance companies today.
So we have 3 hands up. Let's hear the questions and then you can answer them, Len. John Lawrence first, then Ruth, then Adina.
Yes, if the act passed in New York State, how quickly could it be implemented? Would it be likely to get caught up in the court at the state level or the federal level for years, or could the federal government do something to stop implementation at the state level?
Ruth?
Yeah, people talk about the different costs. We spend more. I think it's important to understand who spends more and how that spending happens, because the complications of switching how the money is spent on healthcare is part of why it seems so hard for us to switch over to a more sensible program. So if you can answer that.
And Adina?
I just had one question. It's probably a very minor point about Len's point about Medicare costs not rising. One thing I've been impressed about in the 5 years I've been on Medicare, I think the premium has risen for Medicare B from $183 a month to $233 a month. I'm sorry, the deductible has risen from $183 a year to $233 a year, which doesn't sound okay. That's only $50 per person, but for some people that could be significant. And if you start multiplying it by the number of people on Medicare, that does seem, at least prima facie, to be a significant rise in the cost of Medicare. And I think in the past year, the deductible went something like a rousing $203 to $233 in 1 year, something like that.
Okay, let me try to answer them. The question of the transition, of how quickly could we do it, under the present model of the New York Health Act, which I have to say I don't favor, but a number of us have been looking carefully at this. The present model sets up the structure, but it requires then that the governor come forward back to the legislature with a plan for how to pay for it with the tax structure, and have to also, of course, set up a reimbursement structure for the providers at the same time. So it's a 2-step process. The legislation says this will happen in a year. Well, I don't believe that. I mean, leaving the taxes open to then be negotiated. I mean, my argument is that this is going to be a tough fight to get this. Building a popular movement and enough labor support to get this passed will be very difficult. And doing it twice, once to get this, what in federal terms I would call the authorization bill, and then the appropriations bill, which sets the actual tax rates. Doing it twice seems to me an unbelievable organizing task. So to me, I want to see the fight done once, and so I want the taxes in. And then the question of how long it takes is, it seems to me, it can be done very easily. All we're talking about is changing where doctors send their bills. So, you know, Medicare was started 11 months after it was passed. It passed in 65, the middle of 65. It began July 1st, 66. They had to desegregate the hospitals of this country in that 11-month period, and they started sending checks out, and we didn't have the computer systems that we have today. It can be done. To get the federal money, we already get the federal money now comes to in Medicare. We just have to get them to send it to say, you know, last year, New York's, you know, the federal government sent the state, I don't know, off the top of my head, say maybe $60 billion. Send it to the state, you know, every month, monthly, rather than sending it to individual doctors and individual hospitals. The federal government already does that with Medicaid in the state of Rhode Island. They get an annual total rather than getting reimbursement for every treatment that their Medicaid program provides. So you do have to work out a way of getting the federal money in the state, the federal money, because that's a major part. You know, about half the funding comes from the federal government. That's the situation we have today. In terms of spending, yeah, one of the problems in building support for this is that people don't track how much their healthcare spending is, because it comes in various forms, from the copays when they get a drug from the drugstore to the checks they write when they go to see a doctor, to the premiums that are taken out of their paycheck if they get health insurance from their employer. So, you know, people have to be made aware of how much they're already spending to understand, and then also have some imagination to imagine what it will be like to have a plan where you can see a doctor without having to calculate, can you afford it? But if you need the care, you get it. That's the way it works in other countries, and there's no reason why the richest country in the world can't provide it for its people. On the question of Part B and Medicare, well, Medicare is this very strange animal. Part A provides hospital insurance, and it's tax funded, and it's set up on a social insurance basis, the same way Medicare for All would be, and the same way the New York Health Act is. Part B is set up like private insurance. It's a fixed premium. Everybody, I mean, just 10 years ago when Obamacare was passed, it was made so that people with higher incomes have to pay a higher Part B premium, but the basic structure is a fixed premium for everybody, regardless of your income. And it only provides a quarter of the total funding for Part B. Part B pays medical expenses. I mean, the rest comes from federal general revenues. Now, I don't know what the magic formula is that is used to figure out how much the Part B premium, the deductible and the copays and the premium should go up compared to that influx of 75% of the money come from general federal taxes. But there's some kind of formula that is built in there, but it's not tax funded on a proportional basis the way that Part A is, and the way the New York Health Act would be a tax rate based on income. So if our income, as our wages go up, the taxes go up, and if you contain costs, which is what the rest of the world manages to do, the taxes don't have to change. So the tax revenue goes up with income, and it pays the bills.
So there's a question in the chat. What about the federal money saved from the state switching from a Medicare-based system to a state-run system? Where does that saved money then go? Wouldn't it go to New York State to run their own healthcare system?
Well, there isn't really, the assumption here is not that the federal government won't save any money. At least we're in calculating what the new state taxes have to be, which replace private premiums, private insurance premiums. We assume that the federal government's payments to New York State as a whole will continue at the same level as they are now. But instead of going to individual doctors and individual hospitals, they'll come to the state treasury, and the state will then send them as part of the total trust fund that is created for the New York Health Act. The state will then pay the individual providers. So the feds will be held harmless. That is, they won't save and they won't spend more. Certainly, federal, the Obamacare has a provision for allowing state innovation. And one of its requirements, of course, is that the state innovation not cost the federal government money. And we're not proposing this costs the federal government money or saves the federal government money. But it provides better care for New Yorkers. That's the principle.
So here's another question from the chat, and then Mike Frank has his hand up. From the chat, we consistently make the point that affordable health care is not only a retiree issue. Current data suggests that fewer than 10% of US workers are members of unions, public and private. Can you briefly outline a plan to educate non-union members who are currently spending astronomical amounts of money for health insurance, how to fight back effectively?
Well, I don't have a plan. I am on the board of the Campaign for New York Health, though, and we are educating people through political action and preparing various kinds of educational materials, getting people to tell their stories about how badly the current healthcare system has treated them, so they begin to see what the virtues will be of having a system like that the rest of the world has, where people can get the care they need when they need it and in an affordable way. It is a public education. Both union members and non-members need public education, partly because we're so, as I suggested earlier, we're so embedded within a market system that we can't imagine that there could be a social insurance system where everybody could get the care they needed and the country wouldn't go broke. The truth is just the opposite. The only way the country won't go broke is to have a social insurance system, because the government can contain costs. Private insurance cannot.
Mike, Frank?
The question is related to the previous question, and it may even be redundant. Two parts to it. Although a large percentage of the public supports single payer, as you showed in your chart before, what percentage of New Yorkers are aware of that there is such a thing called the New York Health Act? Second part of the question, what would it take to shift the resistance of unions to this? You gave several reasons why unions are opposed to it, why some unions or major unions are opposed to it. What would it take to break that?
These are deep questions, Mike. I'm not surprised. Public awareness, all I know is that the New York Health Act is the most consequential legislation there is that basically no one has heard of. We don't have the funds. The Campaign for New York Health, of which I'm the treasurer, is completely underfunded, and we do our best, but we certainly haven't been able to run a survey and see who knows about the existence of it. I should say that the politicians know about it. The majority of the state assembly and a majority, basically every Democratic state assemblyman and 33 of the 39 state senators who are Democratic are co-sponsors of the bill. Now, a lot of them have questions about the bill. Will they vote for it if it comes to a vote? I don't believe so. People who know the legislature far better than I say people will co-sponsor a bill because advocates ask them to, but if it comes to a vote, the opposition will be there in large numbers. I mean, every insurance agent who sells health insurance is going to show up in Albany, and they haven't shown up yet because they don't think there's going to be a vote. It's going to take a lot. In terms of union support, it's going to take the unions to realize that the game they're fighting is a losing game. I mean, they just threw the city employees just through, the city unions just threw their retirees under the bus and said, we're not going to provide you any insurance anymore. We'll let Medicare take care of it. And you put yourselves in the hands of private insurers and Medicare Advantage. People have been predicting for years that the rising cost will be unsustainable. I don't know when the breaking point will come, but we're approaching 20% of the GDP, and at some point, healthcare is profitable for insurance companies, but not profitable for the general economy. It costs, every company has to pay. Under our system, every company has to pay these rising premiums. At some point, let me put it in class term. At some point, the capitalist class will decide that a private insurance funded healthcare system is not in their class interest. Hopefully, the labor movement will get there first, but so far it's dragging its feet because it's ironic in a way. Because it is the sort of provider of insurance as a sort of last resort today, it can't conceive of it existing without being a provider of health insurance. And until that becomes so burdensome that or a new wave of unionists comes in and sort of throws out the leadership and says, we need a new kind of unionism that isn't wedded to the health insurance industry, and that will separate out healthcare as a public service and have unions do what they should be doing, which is providing other things for the working class that has to be gotten through their employment.
So do we have time for one more question and then Jim?
No, I think we have to think about winding it up.
There are a couple more questions in the chat, but I think we don't have time for them right now.
Okay, well,
send them to me and I'll be happy to respond.
Len.
Okay.
Len, will your PowerPoint be available to other folks?
Absolutely. I'll send it to you too, and as a PDF, and you can circulate it.
All right, so
the wider the better.
We'll post a link on the PSC website. And meanwhile, I want to thank you for a very clear and very comprehensive presentation. We're going to follow this with a fourth session. Where do we go from here? The last couple of questions engage this issue. How do we increase public consciousness? How do we organize to push the legislature to bring this legislation to perfection and to passage? That's the session we're going to plan next. We don't have a date yet, and we don't have a speaker presenter yet established, but that's what's in store. And clearly, we need to stay in touch. We being everybody who's been on this Zoom meeting tonight, we've got a lot of work to do. Please be sure to fill out the survey. Please stay in touch. Thanks to everybody. And thanks especially to Samantha Sherry for handling tonight's logistics. So Once again, I'm glad you all could make it and stay in touch. Thank you.
Thank you all for listening.
Yeah. Bye.